I'm Demetriou, and today it's Medical Oncology's pleasure to be able to present the Friday morning academic meeting. And in many cases, we present stuff that I think everybody feels, oh, not really relevant to what I do. And they're getting very excited about a progression-free survival of like 3 months. And is it really relevant? But today's topic, I think, is relevant to everybody in the room. And it's probably going to be more relevant with time as this new class, well, newish class of drugs becomes more available and a little bit more accessible in terms of cost. So if there's an organ, it can get an itis. You can get a colitis, you can get a pneumonitis, you can get a nephritis. So any organ in the body can be affected by immunotherapy. The vast majority of patients are either not affected by any side effects or minimally affected. But for those that you do get immune-related side effects, it can be quite dramatic. And Dr. Natalie Irwin, a consultant in our department, is going to give us an overview and an introduction to immunotherapy.
So thank you, Prof. And yes, today I'll be talking a little bit about immunotherapy. And as Prof mentioned, the reason I chose this is I think that it's going to become increasingly relevant to everyone in the room. We are using immunotherapy in an increasingly wide number of cancer types for an increasingly wide number of indications. And the chances are that whether you work in the oncology department, the emergency department, maybe you're a radiologist or you're an internal medicine specialist of any subspecialty, you'll come across a patient now or in the future who's on immunotherapy. These agents aren't readily available in the state sector at the moment unless a patient is on a clinical trial, but they are widely used in the private setting. Yes, so what we'll be looking at today is I'll go a little bit through what immunotherapy is. We'll discuss the different types and what the immune checkpoint inhibitors are. I'll go a little bit into the history of immunotherapy, and then we'll revise some med school immunology so that we can understand the mechanism of action of the immune checkpoint inhibitors. I'll discuss a little bit about what agents are available and when they are used. And then we'll move on to discussing the immune-related adverse events and how that includes the multidisciplinary team in their management. And then just lastly, I'll mention quite a topical area of cancer vaccines, which is newly developing. So when researching for this presentation, across the literature in different articles, this phrase to say that immunotherapy has revolutionized cancer treatment seems to come up again and again. Essentially, immunotherapy is a type of treatment that enhances a patient's immune system to fight cancer or fight disease. If you look at the figure down at the bottom, this shows us sort of the armamentarium of treatments available to treat cancers, and they stretch all the way back to surgical treatments in like 3000 BC, moving on then to radiotherapy, chemotherapy, targeted therapy, which was introduced in the 1980s, and then this immune therapy or checkpoint inhibitors, which were introduced in 2010. The first agent that was approved was an agent called ipilimumab, approved by the FDA in 2011, and that was for the use in metastatic melanomas. And as the use has moved on, we've gone from using it in the metastatic setting, then in adjuvant setting, and more recently in the neoadjuvant setting, so moving from palliative intent to curative intent of using these agents. They are mostly used in solid malignancies, and that's across the board of all the different malignancies, and a couple of hematological malignancies, really just classical Hodgkin's lymphoma and relapsed or refractory mediastinal lymphomas. So this shows the broad category of immunotherapy. And within that, if we look really on the far left-hand side here, the immune checkpoint inhibitors, that's what forms the focus of my discussion today. Within that category, we have the main agents that are used in clinical practice. Those are the PD-1 inhibitors, the PD-L1 inhibitors, and the CTLA-4 inhibitors. But if we sort of expand the more broad definition of immunotherapy, you can see that it also includes monoclonal antibodies, cytokine therapy, so that was things like IL-2, which used to be used quite frequently, and then some newer therapies like oncolytic viruses and cancer vaccines. So to delve a little bit into the history of immunotherapy, and I know I mentioned that really, from clinical use, we were looking at about 2010, but its origins stretch far back to ancient Egyptian and Greek civilizations. The Egyptians were the first to have these anecdotal reports of patients who picked up an infection. They had a high fever, which must have stimulated the immune system, and then they had regression of a tumor. Galen was the first to describe a link between the inflammation and tumors or cancers, and he seemed to think that inflammation was what actually caused tumors to come about. Friedrich Felisen, in the 1800s, he was a German surgeon who was the first to identify that Streptococcus pyogenes caused the skin infection erysipelas. And he was able to describe one case where somebody got erysipelas infection and then had spontaneous regression of a tumor. The main man really with regards to, who's now described as the father of immunotherapy, is someone called William Cooley, who drew some inspiration from Felisen. He was a bone surgeon working in Memorial Hospital in New York, and he also described these cases where patients got erysipelas with a streptococcus infection and then had spontaneous regression of different tumors such as sarcomas, some lymphomas, and testicular carcinomas. He then took it one step further and developed this substance here called Coley's mixture. And that was a sort of fluid. It consisted of a mixture of Streptococcus pyogenes and Serratia, different bacterial organisms he put in it. Some were live, some were attenuated. And he injected these either intramuscularly into the tumor or intravenous injection. And he described that these tumors were then regressed once he injected his mixture. He wrote a number of cases. So he described in his career over about 1,000 different cases where he'd seen responses to tumors. And this was one of the magical articles where he'd described the malignant tumor inoculations. He wasn't a particularly good record keeper, and he wasn't very good at maintaining the consistency of his mixture. And so over time, colleagues and that really sort of rejected his philosophies and his hypotheses. And so the other thing what happened is in the 1960s, the FDA regulations came about. And so Cooley's mixture, which was commercially available, was then taken off the market and really sort of put to one side for a number of years. But at the time, this New York Times article shows that he really was quite celebrated, people describing that many cases of cancers were cured by him. And then wanted to move a little bit further on to Paul Ehrlich. So he was, if Cooley was the father of immunotherapy, that he is the father of immunology. And he was the first to describe that the immune system could recognize a cancer antigen and then eliminate it. And he received the Nobel Prize for his work in immunology. I also wanted to mention something we're a little bit more familiar with, and that's use of the BCG vaccine to treat bladder cancer that hasn't involved or hasn't invaded into the muscle. And that was reported first in 1976. And then lastly, in more recent history, to discuss Honjo and Allison, who shared the Nobel Prize in Medicine and Philosophy and Physiology in 2018 for their work on the immune checkpoint molecules. So Honjo is from Japan, and he described the PD-1 molecule on the T cell surface. And Allison works at the MD Anderson Center in Texas, and he described the CTLA-4 molecule on the T cell. So to then understand a little bit more about how immune checkpoint inhibitors work, I think it's useful to go back to Immunology 101 and really look at the basics. So when a patient has a tumor, a little fragment of that tumor cell is phagocytosed by the antigen-presenting cell, and that's the dendritic cell here in pink. The antigen is processed by the antigen-presenting cell and then presented on an MHC class 1 molecule to the T cell receptor, which is on this naive or innate CD8 positive cytotoxic T cell. When you get co-stimulation, so using these co-stimulatory molecules, you then get activation of that T cell which in turn causes T cell proliferation, cytokine production, and active killing of the tumor cells. That process, so that would be described as the normal function of the immune system to detect and destroy abnormal cells, and that would be described as elimination, the first E of the cancer immunoediting process. Those malignant cells, however, can progressively develop the ability to avoid destruction and elimination by the immune system. And that then brings about a state called immune tolerance or equilibrium, where those cells can survive and persist, and then escape, where they start to grow even more, the tumor becomes clinically detectable, and those cells then start to metastasize. And the way in which it does that is by activating a number of pathways called immunosuppressive pathways. And that is done but with the use of these immune checkpoint molecules, the CTLA4 and PD-1, which are found on the T cell, but then stimulated by this ligand on the cancer cell, which causes inhibition of the T cell. And so essentially what we describe these as is the brakes on the immune system, these molecules. This quite nicely demonstrates, if we start at number 1, where the antigens are released by the tumor cells, then presented to the T cells, which are primed and activated. They then infiltrate into the tumor and then recognize and kill the tumor cells. But if at this point here for priming and activation, you get stimulation of an immune checkpoint inhibitor, in other words, you apply the brakes onto the immune system, you then stop that process from happening. In a sort of complicated double negative way of looking at it, by then using an immune checkpoint inhibitor, you release the brakes on the immune system, allowing the cycle to start again and for the tumor to be then attacked and killed. This then really just demonstrates that system of releasing the brakes. And we can see here how the either anti-PD-1, that monoclonal antibody, binds to the PD-1 receptor, or the ligand then binds to the receptor there, and then in turn causes tumor cell death. So at the moment, the main classes of immune checkpoint inhibitors that are clinically available and mostly used in practice include the PD-1 inhibitors, PD-L1 inhibitors, and the CTLA4 inhibitors. I've highlighted pembrolizumab there up at the top because that's the agent that's probably the most widely available in the private sector and most likely you'll be able to come across that in practice. The others are less commonly used and less widely available. The immune checkpoint inhibitors are used for an increasingly wide number of indications. I mean, we can see here that it ranges everything from head and neck cancer, skin malignancies, including melanoma, squamous cell carcinomas, also used in a number of gastrointestinal problems, hepatocellular carcinoma, colon cancer only in those that are MSI high. It's also used in breast cancer, gastric cancer. There's hematological malignancies, as I mentioned before, widely used in lung cancer, and then also used in bladder cancer. The reason why immune checkpoint inhibitors work in some cancers and not in others is to do with the immunogenicity of the tumor itself. So we describe these cancers, so particularly things like melanomas, as being hot tumors. They are sensitive to immunotherapy, as opposed to a cold tumor. This is something like a pancreatic cancer, which doesn't exert a big immune response, and so immune therapy doesn't work in those settings. In order to decide whether we can or can't use an immune checkpoint inhibitor, we do something called just a simple immunohistochemistry-based stain to look at something called the TPS or the CPS. And depending on what the result of that is, whether that's more than 1%, more than 5%, more than 50%, we can then apply that in each cancer situation to decide whether the immune checkpoint inhibitor is indicated or not. So moving on then to the immune-related adverse events, these are inflammatory side effects. They occur because the immune system is activated and then it starts to react against both the tumor antigen and the antigens on the healthy tissues. They can occur in any organ system. We most commonly see them in the gastrointestinal tract, the endocrine system, and the skin. And more rarely, they would involve the central nervous system, cardiovascular, pulmonary, and in hematological systems. They can occur at any point in time during treatment. So most tend to occur within weeks to 3 months after initiation of treatment. And usually the first ones to appear are the dermatological side effects. There are reports of these side effects occurring even after discontinuation of therapy, and in some cases up to a year after they've been stopped. There are some controversial reports to suggest that those patients who do develop these immune side effects might actually have better treatment efficacy. Although these are a little bit controversial, they haven't fully been studied. One of the reports was to suggest that those that get vitiligo in particular do have a better treatment response to the agents. So this then shows us really that wide spectrum of where these side effects can occur. I've put there on the left-hand side added in fatigue, because that's a major common side effect that we come across with them. But then if we look through the systems, as Prof mentioned, anything with an itis is possible to occur here. Arthritis, myositis in the gastrointestinal system, things like colitis, pancreatitis, pneumonitis, a vast array of skin involvement, ranging anything from vitiligo all the way up to toxic epidermal necrolysis and Stevens-Johnson's. The eyes can be commonly involved, and then the endocrine system, as we mentioned before, and the number of different hormone imbalances there. So in general, these side effects can be all treated with a sort of general approach to their management. There are no prospective trials that have been conducted in order to determine how we manage them. And so the recommendations are based on consensus opinion. And these are published in the Oncology Society guidelines. ESMO and ASCO both have documents to help us with management. They require a high index of suspicion. So this includes educating your patient on what to expect, but also making sure that people such as nurses and emergency medicine doctors in ED are able to recognize and pick up these problems as they occur. They commonly can look like other problems, whether that's a bacterial pneumonia, maybe a bacterial or viral cause of enterocolitis. And so we need to consider the differential diagnoses before we confirm that this is secondary to an immune checkpoint inhibitor. And the general principles of their management are based on what the severity of the side effect is. So they're graded from 1 to 5, ranging from mild, moderate, and severe, and then 4 and 5, which are life-threatening or death-causing, if that's a problem there. Most side effects, anything that is greater than a grade 2, requires delay or withholding of the immune checkpoint inhibitor. Anything that is a grade 2 or more, we need to then use immunosuppression therapy in those cases. Corticosteroids, so something like oral prednisone, is the first line agent that we use. And when we use it, we need to be careful of all the principles that we do when we use corticosteroid therapy, making sure to prescribe it for the shortest duration possible and using the shortest or the lowest dose possible that is effective. These patients then need to be evaluated again after 72 hours. And if they haven't responded or they've worsened in any way, that's when one needs to look at adding additional immunosuppressive agents. The agent that you choose to add depends on the organ system, but might include something like infliximab, tocilizumab, and other agents as well. It's particularly important to involve the disciplinary team when you see a rare presentation, so something you're not used to treating, or something that's severe, these grade 3 and grade 4 side effects. This is a general management protocol of it, and we can see up at the top, they look for any differential diagnoses, and if that's picked up, you treat what that is. You then grade the severity 1, 2, 3, or 4, and decide whether you're going to do just symptomatic therapy, whether an oral steroid is indicated, whether that steroid then needs to go up to a higher dose, and then using your organ-specific second-line immunotherapy. You can see here that in grade 1, the immune checkpoint inhibitor can be continued, but anything from grade 2 onwards, you need to suspend the use of that immune checkpoint inhibitor. This was just a side really to the pillars of management of recognizing these side effects, just noting that it's important to anticipate that they may come, early detection of them, and then treating them as early as possible. So I wanted to delve a little bit into one of the most common side effects that we see, and that's of enterocolitis. And we know that self-limiting diarrhea is one of the most frequently reported immune-related adverse events. They tend to occur more commonly with the CTLA-4 inhibitors as opposed to the PD-1 inhibitors. And they occur much more quicker in those with using CTLA-4 inhibitors than the PD-1 inhibitors. Sometimes we use these agents in combination, and so when that happens, the chance of enterocolitis is much higher. And in some cases, it's being used in patients with pre-existing inflammatory bowel disease, and in those cases, we see that these patients often flare up. A endoscopic evaluation is indicated in anyone with greater than a grade 2 side effect. And this was from the American Gastroenterology Association. They described sort of 2 patterns. At the top, they spoke about a ulcerative colitis-like pattern with erythema, some vascularity, irregularities, and spots of bleeding. And then underneath, they described more of a Crohn's-like pattern with cobblestoning and some deeper ulcerations. And it's suggested that the deeper the ulcerations, the more extensive the findings on endoscopy, the more likely they are to be corticosteroid refractory or need those additional immunosuppressive agents such as infliximab. This was a schematic from the ESMO guidelines on how to manage that enterocolitis. And you can see it's similar to the general principles of management. You look at the grade, and that's depending on the number of loose stools per day, being less than 4, 4 to 6, or more than 7 in grade 3 cases. They start by excluding all the differential diagnoses, sending off that stool for enteropathogens and C. difficile toxin, doing the endoscopic evaluation, and then moving on to withholding that immune checkpoint inhibitor and adding your oral corticosteroids. If they fail, you then introduce your other agents later on. Pneumonitis is a less common side effect, so we don't often see it. Early trials were indicating an incidence of about 2 to 5%, although the real world incidence is probably a little bit higher than that. The reason I mention it is it can be a severe and sometimes irreversible side effect. We see it more commonly in patients who have pre-existing lung cancer, and that's probably because they've got this pre-existing lung damage that was there before. The radiological appearance can vary, and so down at the bottom here, we can see the different subtypes they describe as ground glass opacities, maybe a cryptogenic organizing pneumonia-like pattern, or hypersensitivity patterns as well. And so that's where the differential diagnosis becomes quite important there, because that can look like any of the other patterns of lung disease that we see. So important to consider that this could be an infectious pneumonia. If somebody's had prior radiation, is it maybe radiation-related, lymphangitis carcinomatosis, or maybe a pre-existing interstitial lung disease? Once again, they need to be classified according to severity. We look at the classification 1 to 4 from somebody who's asymptomatic, somebody with mild dyspnea, and then symptoms that start to affect their activities of daily living or require urgent intervention. We can also use some radiological findings to distinguish the severity of those side effects as well. Once again, we then treat them according to what the degree of severity is. And you can see really there at the top. So grade 1, there's no indication for bronchoscopy, whereas anything from grade 2 onwards, a bronchoscopy is indicated. In grade 1, the immune checkpoint inhibitor can be continued, whereas grade 2 onwards, we hold the drug and then add steroids for those patients. The duration of steroids is quite a long duration. So from grade 2 onwards, we're looking at 6 weeks of therapy at a minimum. I wanted to mention also just the immune-related endocrine toxicities that we see. And so they describe hypothyroidism and hypophytis as being the most common. The hypophytis tends to occur with ipilimumab, really. That's the agent that seems to be the causative agent there. Their management can be quite challenging. And this is because their side effects differ from the other immune-related events. They can persist even after we discontinue the immune checkpoint inhibitor, and that gland rarely actually recovers its function. They require often long-term or lifelong hormone replacement therapy. And in most cases, we don't actually have to use the high-dose corticosteroids. We then need to consider if after these side effects have resolved, if therapy can be resumed. And that all depends on what the severity of the initial immune reaction was. Those who've had a grade 3 or grade 4 event are much more likely to redevelop that same side effect. And so in most cases of a grade 4 side effect, we wouldn't re-challenge the agent. In a grade 3 side effect, it needs to be carefully balanced, considered within the multidisciplinary team to look at what the benefits of continuing treatment are versus the immune-related toxicities that might develop. You can change the agent. So if it occurred on a PD-1 inhibitor, you could change to a CTLA-4 inhibitor and are unlikely to see that side effect recurring by changing the agent. I wanted also to mention the use of immune checkpoint inhibitors in patients that have a pre-existing autoimmune or rheumatological condition. And so for a number of years, these patients were actually excluded from the trials that looked at immune checkpoint inhibitors because of concern that they might flare up. In the real world, however, patients with autoimmune conditions have been given immune checkpoint inhibitors. They do seem to derive the same clinical benefits with an acceptable safety profile, but there are definite reports that they are at increased risk of disease flare when they're given these agents. A question still remains about what immunosuppressive regimen should these patients be on at the time that you start your immune therapy, and research is ongoing to look at that. And then this is my last slide, just to mention cancer vaccines. And the reason I put this in is because there's been a lot more interest regarding them around about the time of the development of the COVID vaccine and mRNA-based vaccines. They're described as the next immunotherapy frontier. And they can be divided into something called a preventative cancer vaccine. And so that would be something like hepatitis B vaccine or HPV vaccine versus a therapeutic cancer vaccine in which a tumor neoantigen is harvested and then re-injected either into the intramuscularly or intratumorally to then stimulate this immune response, and we hope to then get antigen release and recognition in cancer cells and killing of cancer cells. And so this is a new frontier that we anticipate new developments in. Thank you.